Good morning, good afternoon. Hello, everyone, wherever you're at. Welcome again to another live Facebook session, feedback session on the EAMC 3.0 series that we had this year. We started in January to March 2022. Today, we've got some of our participants from Uganda join us today to actually tell us about their experience on the training and also what they've learned and how they are using this in practice in their communities. So we're just going to go round to do a bit of introduction. Torie?
Hello, everybody. Thanks for tuning in to our feedback session again today. Yes, my name is Torie Robinson. I'm a podcast host and YouTuber for Epilepsy Sparks Insights, and I'm the founder of Epilepsy Sparks. I'm also a person with epilepsy, had a temporal lobectomy and take multiple medications, and also one of my passions is epilepsy research and the comorbidities of the epilepsies, because sometimes the comorbidities can be even more negatively impactful than the seizures alone.
I'm Dr. Ariane Dora Niteka. I'm working in Uganda, Kampala, Bethesda Medical Center, and I'm looking for the health of refugees in Kampala and in Nakivale refugee camp.
Damyano?
Hello, everyone. I'm a psychiatric clinical officer by professional, and currently I'm working as a mental health officer with IRS International Rescue Committee based in Bwete refugee settlement, that's northern Uganda. As you all know, that in Uganda, epilepsy, much of the people are sent to mental health services. Thank you.
Lovely to meet you all. And I'm Tolu Olaniyan. I'm the CEO of Pretola Global Health and the founder of the Pretola Global Health. I'm quite excited about today's talk because we're coming at it from a different perspective. And Torie and I had a bit of a conversation and chat about this. And it's opening my eyes actually to a different community that I've not thought about before, in the sense of people that have been displaced, either due to war or due to famine or due to other, circumstances. They've been displaced from their original country, and they've had to move to another country to survive, to live. And Ariane and Damyano, they both work in different parts of Uganda, but support the refugee communities in those parts. And we would love to actually know a little bit more, just have a bit of an insight, understanding into the needs of the people, where they're from, and how do they live where they are. Ariane, do you want to share a little bit about the community that you support?
Okay, the refugee population is have their particular issues, as you have said. They are coming from different countries, torn out by war. In their lives, they have made a lot of challenges, not only back in their countries where they were fleeing bombs, guns, and so on, but they met a lot of challenges here in this country, like refugees, because they have left their belongings behind. They have been separated with their families members. They don't know if they are living or if they are dead. They are here as people who know they don't have lands to cultivate, they don't have businesses to run, they don't have, and the support of humanitarian agencies are very little, almost $4 per individual and per month. It's very, very little. So they struggle to live, they struggle to eat, they struggle to educate their their children.
Thank you. And Damyano, I'm guessing epilepsy is a common condition you see in the people you support in your community.
When we look at Bwete settlement, epilepsy is one of the commonest conditions we see under mental health services. For instance, on average, every month we make 70 consultations of clients living with epilepsy. And this has been indicated as a huge number based on the settlement we serve. And most of the time, well, one of the findings we have with our clients, with the clients we serve, we find that most of them have been neglected, and they find a lot of stigmatization from the community. For instance, the community members are always abuse them, nickname them, things of which always distress them and further worsen their condition. And also, we found out that there are a number of child-headed families whereby these clients are separated from their family. You find a client is there, but they is in a settlement alone, or is in a settlement with aunts or uncles. And as you know, living without your parents in such conditions, they find a lot of difficulties. Remember, in African setting, when you are with other extended family members, there's a way you feel detached. But now, adding on the effect of epilepsy, they are so much discriminated. Like, you find they don't allow them to associate it near them. They always, at times, they nickname them. There's a lot of discrimination among people living with epilepsy.
And really, just trying to think, put yourself in the shoes of these individuals. They don't just have a condition, they have epilepsy, but they're trying to survive where they've been displaced and a whole lot of other things, and trauma that's come as they've experienced as a result of their situation.
Yeah, actually, that's a really good subject actually to bring up, is how people may have epilepsy, but there's a lot else actually in their lives, which, yes, can contribute, of course, to the epilepsy, but a lot of other traumatic things, but also I think can be quite inspiring things as well. And I'll give you an example. One of my ex-neighbours was actually in a refugee camp for 2 years. One country wouldn't have them. And then eventually the poor people ended up in the UK. This was 50 years ago. But they went through a lot of trauma and they didn't have epilepsy. So I think that, for me personally, that gave me sort of a little bit of insight to what it can be like to be a refugee, just a tiny slither. But that's why I think it's really interesting to hear what it's like from you two, Ariane and Damyano, about what it's like to have epilepsy and non-epileptic seizures, often in addition. So, Ariane, what would you say about that? Is there something that you learned from the course that could benefit those individuals and families affected by both epilepsy and mental health conditions and PNES, etc.?
Psychogenic seizures, there are many, especially in teenagers. We encounter PNE mostly in teenagers because most of them, when you are talking, you are discussing the problems behind, you find out that they are fed up by the hardship of life they are living here in refugee. And as a refugee, they recall how they used to live back in their countries, how they used to go at school without any problem. But here they are on and off at school because of the school fees are very difficult to get for their parents. The food is very difficult to get. Maybe they used to eat 3 times a day or 4 times a day. Now they're eating 1 time a day. There is like a battle in their feelings.
Just to try and understand what you're saying and describing to us is the reason, because Torie mentioned PNES, which is psychogenic non-epileptic seizures. So they are events that mimic epilepsy, presents like epilepsy, but they're not epileptic seizures. And you were saying that you've observed quite a lot of that in young, in teenagers and the young population there. And this could be as a result of the trauma and the ongoing psychological impact of their situation.
Thank you for that insight, Ariane. Damyano, could you tell us a little bit from your side, the benefits that you got from the training that what you've learned that you'll be able to implement to help the patients and families that you work with?
From the training, one of the most essential thing I grasped is the more involvement of caretakers. And this time around, looking at the primary caretaker with whom the client is living with, plus the community, because we realize that on top of just giving, because most of the times we've been just giving drugs, and maybe once and talk to the client herself or himself, but now from the training, we recognize that there's an aspect which we've been missing a little bit, maybe due to, there are some things which we've been not paying close attention to it. We used to only consider them at the clinic, but now from the training, I recognize that there will be a more need to further follow these clients, even to their homes, engage the community. Because as I said earlier, one of the most complicating or precipitating factor in their seizures is the situation they are living in, stigmatization and abuses, insults due to their illnesses or to their attacks. That's actually turned out to be one of the most things that worsens or is hindering the progress of the clients we serve.
That's lovely to hear. And actually, I wanted to ask you, because I understand that you specialize in mental health as well, which is fantastic. Did the course enable you in any way to distinguish between the neurological disease, which is epilepsy, and then psychological or mental health issues? So are you able to distinguish between the two and see how those often come hand in hand?
Yes, the course further helped me to identify the comorbidities that can happen between epilepsy and other mental disorders, most of the childhood disorders like the autistic disorders, the intellectual disability, how they can comorbid with the epilepsy. And I got more insight on how to handle the comorbidities, just in case a child or a client is having comorbidities. So I learned more how to handle the pharmacological bit of it, which drugs to use, and how best to educate the family, so that what are the expectations out of the expectations of the treatment or the management, so that the family and the client, they get to know the possible outcomes of the management plan, and so that they can be aware that maybe this is not just a 2 or 3 days management, but it's an ongoing management which will take time, so that they can further improve. And to what extent can the management take them?
Great, thank you so much, Damyano. And Ariane, I just want to ask you as well, actually, similar question. So did the training help give you insight into how comorbidities, or what are seen as comorbidities, can actually sometimes be the priority for the patient and family? Because often we find, and we've brought this up in other conversations, haven't we, Tolu, how the epilepsy can sometimes be, well, awful, but it's not the most important thing for a patient or a family. And I imagine, maybe correct me if I'm wrong, sometimes the trauma from being a refugee and all that you go through, the impact on one's mental health could actually be of greater significance and negative impact to a life than perhaps an epilepsy. Have you come across that? What are your thoughts?
Yes, I learned a lot about caring the comorbidities, but what I could say, as we had before, like in our program, to do advocacy and awareness. And because what I saw with Prof. Dora, I think.
Dora, yeah.
Dora, yes. It's like there are some other things, in other factors in the environment which can trigger these comorbidities to be worsened. Like the conditions in the families, the lack of mastery of parents, the lack of like the breakage in marriage, because I saw it in Inaki Valley camp. husbands used to quit their wives because of the condition of their child. Just they say like this child is like this because of your families has done this, because they have poisoned the child and so on, and they leave their families. And all those other factors, the environmental factors, they are put like a heavy burden on those children who act with a different behavior. Maybe they are worsened or they develop them just because the other factors. So what we have done right now, when I saw those factors like triggers, we did discussions with families, advocacy in the camp, and awareness, so that they could improve the responsiveness in the neighborhood, in the families, in the those parents who have left the children, and so on. We are targeting that. Why? Because getting the medicine, Torie, getting the medicine is somehow tricky. Yes, I have the knowledge. Yes, the other mental health officers in the camp, they have knowledge, but the supply of the medicine is on and off, and we don't have that money to provide medicine on time. So if we are stuck on that side, we do our best to do other things we could do on another side.
It's a complicated and a complex situation that we do appreciate, the complexities around where you're working, the communities and their needs, and the fact that you're trying to support children, adults, men and women, in these communities with very, very little resources. But then understanding that their needs are varied. They've got the physical health, they've got the, epilepsy, they've got probably other health conditions going on, they've got their social, complicated issues, environments, and a whole lot of that. And that's why we really commend you that you want to learn about, how to be able to support them the more. And do you think, Ariane, Damyano, I'll come to you here. Do you think that the training has helped you to acquire some knowledge? Because you can't learn the training, there's a lot more about epilepsy to learn. But do you think you're able to acquire key knowledge and skills to support the people better?
When it comes to this, actually, the training was so much of importance because it was tailored on the essential drugs at least which are available. At least you are given how the alternatives are. As Dora has just said, the inconsistency in essential supplies, it always affects across all settlements, and you find yourself all in and with a number of outstocks of various commodities. But the training helped us to know the basics on how to switch in case of anything, how you can deal along, how you can help clients living with epilepsy with the basic drugs which may be available. Because that since these are displaced people, they cannot afford even to sustain buying those drugs, given their nature. They are very expensive, even if they are basic, but they are expensive and they can't afford it. But the training was so essential that we were able, it was tailored on the readily available drugs that you can use to help these people out. As on top of using the drugs, but also there is the psychosocial beauty of it, so that we can handle both. We can use the multi-sectorial approach of management, so that we can manage them physically, psychologically, and socially, so that they can get a relatively fair life to live and improve their quality of life.
Thank you. Thank
Thank
you.
you.
And really, thinking of the session we had with Dr. Sally Baxendale, which is around the neuropsychological impact and comorbidities that of epilepsy, was really good, that session, and how you can support people with regards to anxiety, depression, assess them and provide support, which is why I think Ariane was talking about that. We may not have the medicine. There'll be times when we don't even have the anti-seizures that we need, but then can we support them on other aspects till when we can get, so there shouldn't be times when we don't have access to these meds, but the reality is that there are times that it's not available, but what can we do? How can we support them? So I really do appreciate the complex situation. And then I wanted to talk about this because we were talking about this before we came on live. Ariane, you were talking about the women session, the women topic with Kim Molly, and what you learned and how that was an eye opener for you. Do you want to share a little bit more about that?
I learned a lot about epilepsy and women. It was like implementing in me to be very cautious with women when I receive them in consultations, to see how epilepsy is affecting, epilepsy itself is affecting her life, the reproductive life of women, their fertility, their quality of life in general, the comorbidities, how medicine is also playing a role in their reproductive health, trying to explain to them, discuss with them, trying to avoid unwanted pregnancy or unplanned, let me say unplanned pregnancies. I came to know how to change medicine for those women when they want to get pregnancy. I came to know how to handle them when they are pregnant, what to avoid, what risk factors to look at to avoid serious complications in pregnancies. Okay, I learned a lot about women.
Really, thank you. I really enjoyed that session and the feedback we had about all of the sessions, and the TSC, the tuberous sclerosis complex one as well. So just reflecting on all we've discussed today, and Torie, like we always say, it's not just about the seizures. See, it's obvious with everyone with epilepsy, but much more so with the refugee community, that it's not just about the seizures. There's a whole lot more going on, and there's hence the need for multidisciplinary approach, isn't it, Torie?
100%. You summarized that very, very well, Tolu. It's a whole lot more than the seizures alone. And you actually made me think of a conversation, just a quick thing here, I had with a clinician recently, and we were talking about parents whose child had epilepsy, and they only timed the seizure from the moment their child started shaking in a tonic-clonic. They didn't realize that the child was having a type of focal seizure beforehand, and it became a secondary generalized. And so, you know, it's so important to have families educated on the epilepsies from clinicians as well, so they can think, actually, my kid is looking a bit funny, and that's when the seizure is starting, rather than later on when the shaking starts. I think that's really important.
Just wanted to say this really about the refugee population.
Mm-hmm.
And this is new to me. I've talked about epilepsy with regards to different population, but actually I don't even know, like, it's basically something I started thinking about when the Ukraine war started.
Right.
Because it became very, very evident that there's an issue here. And listening to your podcast, Torie, and also reading and learning more about the impacts of wars on people with long-term conditions and on people with disabilities, because I remember sitting back when the Ukraine war started and people were being evacuated and just wondering, how are the elderly, the young, pregnant women, and then what about children, people with developmental disabilities, that complex health needs, that are using the wheelchair, on oxygen tanks. And I just sat back thinking, oh my goodness, the impact of wars on communities, it's just immense. And now thinking about wars taking place that have been taking place for years, taking place and probably ended, but the impact of it over the years, people have been displaced from Burundi and the lot in different countries to countries like Uganda. And then you now think about the impact of the trauma they've experienced, that they are still experiencing, being able to integrate them back into the community, access to healthcare. That in itself are things we need to put into perspective. And I know in the country, in our beloved country, UK, there are ongoing conversations about the refugee community. I think there are things we really need to think about when we're making policies and decisions about this group of people, on how we can help them to overcome, to some extent, the trauma.
To help empower them, I think.
Exactly.
Isn't it?
Exactly. We can't re-traumatize them, if there's a word like that. Make them go through this experiences all over again by not helping them to integrate into our community's story.
So for people who are familiar, at least to a degree, about the Ukraine crisis, well, that's because that's been, although it's not publicized so much now, it's because it's still ongoing. We must remember that. About what's happening with the refugees coming into Uganda, we didn't hear about that, right, Tolu?
No.
That is not publicized, and that is in the general press in other countries, and no doubt that is going on in multiple countries. Similar situation, particularly low to middle income countries, and we have our fellow humans there whose lives are as valuable as people from Ukraine. So we need to realize that, okay, we have millions of other people around the world who are equally deserving of care. And clinicians out there equally need to be aware of and understand the epilepsies and the comorbidities. And just one more thing as well, we talk about how, people struggle with access to drugs. Yeah, it's a huge, huge issue. But there are other things which are really, people don't think about. For instance, if there's war or stress, often patients will have lack of sleep. Now, what does lack of sleep cause? Seizures, so commonly, right? People will be, have extreme emotion. So like lots of kids, for instance, many people don't know, if they get too excited, they can have seizures. Actually, it happens in adults sometimes too. But the same goes if you get too stressed. What does war cause? Absolute stress and trauma. So we have perfect environment, not just for new cases of the epilepsies and psychiatric comorbidities, but for worsening of people who already have the epilepsies. So it's really important to keep that in our minds, and also realize that if we don't have access to all the drugs we need, if we don't, and it sounds like Ariane, you and you, Damyano, are doing this, is that there are other ways in which we can improve these patients' lives. So if it's just trying to make people slightly more content, make them know that they are not forgotten, make them, create a slightly better family environment if possible, that can help calm people down a little bit, and at least to a degree, sometimes minimize their seizure risk. So it's looking at the whole picture. I think a lot of the time it is very, very important. And it sounds like you guys are doing that.
Yeah, and as a clinician, I now think about my peers like Ariane and Damyano that are working in communities with trying to support people that are going through this situation. So really, epilepsy is broad, but communities, just looking at comments by Nina Mago saying communities are broad, and whatever community it may be, all these people deserve good healthcare services, and people with epilepsy need that. they need to have access to clinicians that understand their need. They need to have access to clinicians that have been trained to be able to assess and provide care with whatever resources they've got. They need to have access to assessments, EEGs, MRIs, and the lot, and treatment options as well, just like everybody else across the world. But these are the treatment gap we are talking about. These are the treatment gap we've been talking about over the years on epilepsy. These are some of it. These communities that are not so visible, but really they've got epilepsy and they need the care just like everybody else. So a touching session today, a different tone to whatever we've done in the past, an interesting one, but also a reflective one as well, where everyone, clinicians, providers, those in a place of power, actually need to reflect on how we can best support people within these communities. I'm just going to pick a couple of comments on Facebook. Stigma can turn out to be an issue much bigger than the epilepsy one is battling, which is true, really true. It takes a multidisciplinary approach to manage that. And how do we develop that approach? And that's why Ariane and Damyano joined the training with over 30 other clinicians from Uganda. They joined the training, learned a lot from clinicians from different countries, also networked with others as well. And we do hope that some of the things you've learned, all of the things you've learned, you'll be able to actually use them to improve care in your countries, and it's helped as well. Torie, any parting words from you before we go?
I just want to say that, I'm uplifted and rather excited about the future, and how by working together, all of us from different parts of the world can share our knowledge to improve the lives of other people. And I say that from the heart as a patient, thinking about families and thinking about society overall. And everybody, if you agree with me in that statement and agree with valuing the lives of people affected by epilepsies, please share this with anybody that you know, and bring it up with a politician or two. That could be useful.
Ariane?
I have a dream, me and my friends who are interested in epilepsy, to make the care more holistic for these patients, not only focusing on the patient himself alone, but the whole family. It means we are dreaming, we dream that clinical approach. We dream to help those families to educate their children. We dream those families to have to grant them, if it's possible, with little capital so that they can run businesses. They can have something to do to improve the daily life in their families. And we dream to accompany families psychologically, because not only the children who are suffering, but the parents also, and the siblings. They have all trauma with the sickness, with the hardship of life, with everything surrounding them.
Yes, you have a dream, and dreams do come true. Damyano, parting words.
I'm so pleased and so grateful that at least we were Ugandan clinicians were part of this training. It will help us a lot, because formerly, or as I said before, people with epilepsy were only sent to mental health department, and whereby the mental health personnel were very few in Uganda. But now with this training, at least, and I was happy that many clinicians and nurses, they joined, they got sufficient knowledge that this is, and will be of great importance if at all disseminate this information to our respective facilities where we serve, so that many other health workforce can join hands in helping clients living with epilepsy, so that at least that gap of accessing medical services can be bridged. Also, just like Dora, also have dreams as well. You know, with me and some other colleagues of mine whom we share places of origin. We very much know we are all serving different refugee settlements from various parts of the country. But also we are trying to organize ourselves to see how best as well we can serve our home region. So that we are planning to come up with a joint, maybe a CBO, to see that we create more awareness, just like we are serving people from the humanitarian settings, but also our mothers, our sisters, our brothers, they as well need the same services, and we are serving people from far. So we are dreaming to organize ourselves to see that at least even our relatives, friends, and in-laws can as well benefit from the knowledge we achieved from school and from this training, so that we can together have a Uganda with quality services when it comes to epilepsy and other mental health issues, so that we can live a productive life. As you very much know that there is no life or there is no health without mental health. Mental health should be a core source of health, because someone who's not mentally okay, of course, is not productive in the community, and that will lag our country behind in the low classes. So if at all we have our issues to say that our country can at least progress to at least middle class, then we have to be having people who can be productive in the community. That's one of the best dreams we are thinking of.
Thank you so much, Damyano. And really, there's strength in numbers. The more you guys can work together, speak up together, liaise together. I know, Ariane, you're in Kampala. Damyano is somewhere in the north of the country. But work together. As you can see, we are in the UK. We can connect with you guys in your country. Now there are ways through which you can. It doesn't have to be face to face anymore, but just start to network and start to support each other to actually raise awareness about the needs of people with epilepsy. And I also wanted to say that we all know that epilepsy is not a mental health condition, but most of the time, very commonly associated with psychological and psychiatric comorbidities. And we know that a lot of countries, low middle income countries, epilepsy is under their mental health services, which there's some, controversial discussions around that. But it's also recognizing the comorbidities that can come with epilepsy. So we really do appreciate having you all on the training. And my parting words is when we put together the EAMC, I never thought that we would have clinicians from the supporting the refugee communities, because like I said, this is new to me. I never thought that the impact would reach that wide. So I want to say thank you to you guys for actually educating me. Torie, I listened to your podcast, but for some strange reason, it just never clicked as to the fact that the need is huge. I'm just like, wow. And the fact that we can support clinicians to actually acquire some of the skills they need to improve the care needs in that community is just really, I'm blown away. So thank you all for sharing with us today. Thank you for joining in. And there's a question on Facebook about what's the training and how can we join the training. The next cohort is next year, January, and it is for clinicians. The next cohort will be for clinicians. So you have to be a registered clinician that work with people with epilepsy in a low middle income country. If you want to know more about the training, send us an email on info@pretolajt.net. we'll put the email on the chat section of this video. Send us an email, and towards the end of the year, registration will start for next year's training, and people can register on it to also learn more. Well, thank you all so much. Thank you, Dr. Ariane, Dora, Niteka, and thank you, Torie. Thank you, Damyano, Bwete, and thank you for sharing with us. Thank you to everyone that's joined us live on Facebook, commented, and those that will watch back later. Do have a lovely afternoon.